Thank you very much for all that have joined us today. As Susan from Woodbury has said, my name is Dr. Michael Ruma. I am a maternal fetal medicine specialist, work primarily in private practice in Albuquerque, New Mexico, and also have the fun and enjoyment and opportunity to work as the Associate Medical Director for Hologic in the perinatal division. Greatly appreciate your attendance today. Very excited to have you with us. Very pertinent time to get together in this virtual environment to talk about preterm labor management, one of the most common things that we address as obstetricians, labor and delivery nurses, family practice docs, nurse midwives, whatever your role is. This is a very important part of obstetric management and is particularly important during a public health crisis, which I know you all know that we're in. We have a very exciting year planned for you as we've moved from in-person meetings and in-person lectures that I know we all love and enjoy. We have moved on to this virtual environment, which allows us really to bring countries together, nations and states together. It's been really quite exciting to visit with a way broader audience than maybe we get at an in-person meeting. We've set up a very nice 2021 educational webinar series that Hologic is supporting, and that is entitled Preterm Labor, Current Advances and Evolving Research. Today's talk is the start of that in February. We have some excellent and very well-known and very important folks in the world of MFM to speak to you in the coming months. In April, we have Dr. Brian Irier. He's the managing partner at High Risk Pregnancy Center in Las Vegas. You will also know him because he is the former president just last year for the Society of Maternal Fetal Medicine. And he's going to be talking about the importance of standardization and more so about the actual behavioral necessities of how we implement change in medicine. And I know you all love that, and I hope you pay attention to your email. We'll definitely be advertising that. In June, we have Dr. Cynthia Giamfi-Bannerman, professor of OBGYN, also vice chair of the American College of Obstetricians and Gynecology Clinical Consensus Committee in Obstetrics. Spectacular speaker, very famous researcher in our field, well known for the New England Journal of Medicine antenatal late preterm steroids trial. She's going to be speaking about a very unique topic, that about triage management of late preterm birth and all of the new items in that field. And then in August, we're going to talk about twins and preterm birth. And we have some great MFMs from Maternal Fetal Medicine Associates in Manhattan, Dr. Andre Rebarber, Dr. Nathan Fox, two very well-known individuals. Very grateful to these folks for allowing us to have some of their time to share their expertise with all of you. So please pay attention to that. Check your emails and make sure you register for those upcoming talks. Anytime somebody gives a lecture to you, we now get the fun of sharing different disclosures with you. I am first and foremost a private practice maternal fetal medicine specialist. I also do fun consulting work with Hologic, a company called CCSI, and Philips Ultrasound. These are entities that I enjoy working with, act as speakers for them, consultants about new things coming up, and doing some research to really all improve how we take care of pregnant women in the United States and around the world. There are a variety of objectives I'd like to cover today. We're going to talk about the COVID-19 pandemic as an introduction to the importance of protocols and standardization. We're going to talk then and transition into one of my favorite topics, talking about preterm labor. Why do we want to talk about preterm labor? It's the #1 most common reason somebody's going to show up in your obstetric triage. So it might be really pertinent today to know how to efficiently do that. And we're going to talk about the tools, fetal fibronectin, transvaginal ultrasound, how best to evaluate those individuals. There's a lot of research on this topic, as you might guess, and we're going to talk about the effects of protocols on patients that have symptoms of preterm labor. We'll roll into some of the causality of that. Sexually transmitted infections have a role in causing preterm birth. We need to remember to make sure that we are evaluating patients for STIs and to make sure we treat them. Talk about some of the treatment guidelines that I think are somewhat new. I love giving lectures because it always brings to my new knowledge to me as a speaker. And I think you'll be surprised some of the recommendations that are out there that you may not be completely aware of. And then lastly, really talk about the importance of continuing routine medical and obstetric care for all pregnant women, people desiring to become pregnant in the COVID-19 pandemic, which is ongoing. This has been, as you know, quite a roller coaster ride for us in healthcare. I started giving lectures in regards to COVID-19 in just the end of March, early April, when there were barely any cases in the world. Since, just as a recollection, we have now passed in the United States the 365-day mark. January 21st was the first recorded COVID case in 2020. And we are now well into our second year of the experience of this global pandemic. As of February 1st, 103 million cases globally with 2.2 million deaths, a 2.2% death rate. I think it takes a moment of pause and some respect and reflection on that. This is a serious disease process. 1 in 50 death rate is not something to blink an eye at. And I think we definitely need to keep that in mind as we continue to advocate for pregnant women and all patients that have coronavirus and risks for it. This is the 10 most affected countries in the world, 7-day moving average. You can see the United States in green. We are obviously having the highest peak in the entire world. And that peak maybe is starting to downtrend. There's about 46 states in the United States that are reporting decreases in COVID cases. My hope is that's actually true. This is a heat map of intensities. Obviously, the darker red areas are more frequent, more per capita cases of COVID. As of February 1st, 26 million cases of COVID with almost 500,000 deaths. In the United States, we have extraordinarily good medical care, and our death rate is slightly lower than that of the globe at around 1.7%. But this death rate still is close to 1 in 50 for all individuals. This is our moving average in the United States, rapidly rising. We had a few peaks early in March, then again in the summer. Then we had our holiday period, Thanksgiving, Christmas, Hanukkah, and all of our travel. And we're now continuing to peak in a rapid exponential escalation in the cases of COVID throughout the United States. This escalation is not just in people and infections in humans, but we've had a rapid escalation in actual literature published about COVID and specifically about COVID and pregnancy. And so I think it's really important to reflect on this as well, because there is just a drastic amount of information to learn and understand about this disease process overall for all people, but also specifically for patients that are pregnant. When this just started as of April, within a month, we had almost 100 articles published. By summer, 700, 10-fold higher number of articles. And we now today, 1,800 plus articles specifically written about COVID and pregnancy. You can't keep up with this. So it's why it's so important to come to lectures like this to try to absorb as much information, the top information out there for yourselves. In the United States, we are well aware that the people that we take care of, pregnant women, have major potential complications about getting and having COVID as an infection. Pregnant women have a higher death rate. Although it is uniquely small in number, it is distinctly and notable in research that pregnant women have a higher death rate in comparison to non-pregnant individuals. It also just makes pregnant women have significant anxiety about how they're going to get care. How do they access care? Is it safe to go to the hospital? Should they go to the hospital? Should they see us? Should they do telemedicine visits? And personally, I've witnessed this issue. We are doing a lot of telemedicine. We're doing a lot of in-person visits, but there is complexity to that. I've seen patients with missed RhoGAM injections, missed glucose tests, missed blood counts, missed variety of different circumstances that they're missing the opportunity. This raises anxiety and a lot of questions for the patients we take care of. And as typical for most viruses, we know that typically viruses cause inflammation, damage to the amnion and chorion, precipitate problems for the fetus, which maybe signal us to go into preterm birth. There is a detectable greater preterm birth rate with patients who undergo COVID infection. We finally have some major tools to fight against this. 2 vaccines approved under emergency use authorization, maybe another one in the future from Johnson & Johnson, a single shot regimen coming up soon, potentially in late February, early March. The 2 existing today, just to make sure that you're well aware of them, Pfizer-BioNTech messenger RNA vaccine can be given to 16-year-old and above. It's a 2-dose regimen, 21 days apart. And the Moderna mRNA vaccine, 18 years and older, 2-dose regimen, 28 days apart. Very limited difference between these 2 types of vaccines. One kept in a super freezer, one kept in a regular freezer. The amazing thing about messenger RNA vaccine, these 2 studies demonstrated nearly identical accuracy in reducing severe COVID infections by 94 and 95%. Very important to be able to tell patients that you have 2 huge 50,000 patient studies done that showed almost identical results. It provides reproducibility, which is incredibly important in research. The Johnson & Johnson vaccine, at least preliminary data that's not been completely released, but showing similar efficacy, maybe slightly less, but still profoundly beneficial to all individuals that want to avoid getting a COVID infection. And we shouldn't forget about pregnant women who want to avoid getting a COVID infection. Great controversy about vaccinations always in pregnant women. Number one, why? We don't include pregnant women in vaccine trials. Please take as a plug for me personally as an MFM, for you that take care of pregnant women today, we need to encourage drug companies, our government, to require that we include pregnant women in vaccine clinical trials so that we can have solid information to protect them. To date, though, we don't have any explicit pregnant women that were included in the Pfizer or Moderna studies. That said, there were pregnant women that actually got their vaccine and became pregnant. The numbers are very small, but those women we know have had ongoing normal pregnancies and no different side effects really than any other individual that's not pregnant. Experts at the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, the Centers for Disease Control, the FDA, Dr. Fauci, believe it is safe to administer vaccines to pregnant patients. Messenger RNA vaccines don't contain any live virus. They don't contain any viral particles at all. And so we skip the viral introduction into our body, which causes our own cells to make messenger RNA. We instead introduce messenger RNA that then makes an IgG antibody to the COVID spike protein. These things do not enter our nucleus. They do not alter our DNA anyways. And the mRNAs do not last very long. They're very fragile. They cause an immune response and they're gone. They definitely also cannot cause COVID-19 infection in a recipient of the vaccine. And so the takeaway is we want to encourage pregnant and breastfeeding women to obtain COVID-19 vaccines to protect them because they are at an increased risk for severe illness. In a CDC report of about 23,000 pregnant women, and including other folks, we know that in people that have SARS-CoV-2 infection when they're pregnant, they have higher rates of intensive care unit admission. 10% versus 3%, or 10%, excuse me, 10.5 versus 3.9 in 1,000 cases, markedly higher admission rate, about 3-fold higher to go to the intensive care unit if you're pregnant and have COVID. You're also almost 2.5 to 3 times higher chance you're going to be invasively ventilated, intubated, placed on a mechanical ventilator if you're pregnant when you get COVID. And your death rate is about almost 2 times as high if you have COVID when you're pregnant. The takeaway on this, although the inherent numbers are small, pregnant women, as per usual, whether it's influenza, whether it's COVID, they have a higher complication rate. And if we don't advocate for our colleagues that are pregnant, our patients that are pregnant, we're going to have them suffer the consequences of that, and we need to be strong advocates for them. There's also disparity seen in race in regards to this as well. Asian women, Native women have higher ICU admissions in particular, and in my state, in New Mexico, of pertinence, we have nearly the largest population of Hispanic women in the Southwest, as well as Native women. They have tremendously higher risks of both COVID-19 infection as well as death in comparison to their non-pregnant peers. And I am sad to express that we have had this experience. We have had now a couple hundred different COVID cases within our own practice. The statistics are very, very true. They have a high rate of hospital admission. They definitely have a percentage of which go to the ICU, which we have experienced. And unfortunately, just 2 weeks ago, we had our first maternal death of a patient who delayed presentation, had limited phone contact, and showed up very, very late in her presentation with her battle against COVID and succumbed to the disease. Pregnant and non-pregnant Black women also are at a greater disproportionate risk of death related to other individuals. And so we need to pay attention to these types of folks and really advocate on behalf of all pregnant women. It's not just ICU admission, ventilation, and death, all of which are extremely bad outcomes, but the baby in utero also can suffer. And we know that COVID-19 positive pregnant women have an increased risk of adverse pregnancy outcomes. In particular, the topic we're going to talk about more is preterm birth. There's a COVID-19 surveillance for emerging threats to mothers and babies network called SETNet, and they're getting information from a variety of different jurisdictions around the United States. At this time, when this was published, 5,000 pregnant women with SARS-CoV-2 infection, preterm birth rate about 13%. This is markedly higher than the general population without COVID. In the United States, we've had a slightly rising preterm birth rate of around 9 to 10% year after year. About 70% of those are spontaneous preterm births related either to preterm labor or PPROM, and about 30 to 25% of them related to preeclampsia, growth restriction, and things that we as MFMs and OBs and family, we tell folks that they need to deliver. We know, though, that COVID is increasing our preterm birth rate, and so we need to be readily aware of how to take care of these patients. Fortunately, our newborn colleagues tend to have very low positive rates, about a 1 in 50 chance if they're born to a mom that has COVID. So we should provide reassurance to moms and that their children are not going to be positive. 98% are going to have a negative COVID test. And even these 2%, the great majority of them do reasonably well. Of the 16 infants out of this 610 set, 8 who were positive for COVID-19, they were born preterm. So that's really important to pay attention to. And 50% of them required ICU admission. So if you have a pretermer, very likely related to RDS, and then on top of that, a viral infection with COVID, that neonate's going to end up in the intensive care unit. Of the 8 infants born at term who had positive test results, fortunately only 1, so 12.5% risk of going to require NICU care. So if a baby's born at term to a COVID positive mom, really unlikely that that baby is going to need any care in an NICU. How do we take care of these folks? In general, as a maternal fetal medicine specialist, I think the biggest, most important part of my job is to try to encourage people to take care of the pregnant patient in the same fashion as we would take care of them if they were not pregnant. We know the treatment in non-pregnant individuals for COVID-19 is evolving, it's uncertain, the research is growing, we have new drugs, and so we should try to mimic what we're doing in non-pregnant individuals. First and foremost, low threshold to initiate oxygen. We want to maintain O2 sats for moms at least at 94 to 95% and above. We should not tolerate COVID infection patients having 89, 90%. We want to give early oxygenation, which has been shown to be beneficial to them. We know pregnant women are hypercoagulable by themselves. Just by simply being pregnant, they have an increased rate of venous thromboembolism. And so with the infection, whether it's related to the infection or whether it's related to the fact that they're often very sedentary, during a hospitalization for COVID-19, we want to make sure that we put them on prophylactically dosed anticoagulation. Because of the complexities, if they are anywhere in a gestational age where they may need to be delivered, I would really encourage you to utilize heparin 10,000 units sub-Q BID because of its short half-life. If they're very, very early in their pregnancy along with COVID and have a hospitalization, enoxaparin 40 milligrams sub-Q once a day, certainly useful as a prophylactic, but you have to understand enoxaparin has a longer half-life. Heparin gives us a lot of flexibility. If we need to operate on that patient because she's having respiratory issues, we can move towards delivery rapidly without worry about bleeding. Early initiation of glucocorticoid therapy is important for any hospitalized pregnant patient, particularly when they are on oxygen. Oxygen requirement is kind of the key for thought process on do we need to initiate medications for these patients. Dexamethasone 6 milligrams PO daily for 10 days or until they're discharged is the standard recommendation. Please keep in mind, though, we often may need to deliver a preterm patient with COVID who's pregnant. And so we want to prepare that baby for the outside world. So I would recommend starting in anyone who's from 23 to 36 and 6, that we give them dexamethasone 6 milligrams intramuscular. Please don't give it IV. It needs to go in IM, Q12 for 4 doses. That's given, that will help the mom, but it's also going to help the baby to reduce the risk for respiratory distress syndrome. Then we want to switch the patient to methylprednisolone, 32 milligrams PO or IV to complete a 10-day course up until they're discharged. We also want to give the patient Tylenol. Tylenol is the preferred antiemetic, so we want to make sure that we give any patient who has a fever, first trimester, second or third trimester, acetaminophen to treat their fever. And we have had good experience with remdesivir. Studies have also demonstrated it's very well tolerated in pregnant patients. And so when you're starting a patient on oxygen, they have chest x-ray changes and they have COVID-19 and are pregnant, I'd really encourage Dex and remdesivir given in concurrent scenario because of the benefits given to them. We have seen the best outcomes in pregnant women when we initiate early treatment for these folks and don't think too much and don't delay. Remdesivir, 200 milligrams IV times 1, then it's 100 milligrams for 4 days IV or until discharge. If they have a slow recovery, we can use this for up to 10 days. Don't forget about the baby. The mom has lots of vital signs. We can look at her respiratory rate. We can look at her temperature. We can look at her pulse. We can also look at the baby. Really important to look at that baby because maybe the baby is not doing well in that mom who's maybe not oxygenating well. And so we want to make sure these patients are on a fetal monitor because that may be an indication to move in a different direction. At 32 to 34 weeks, I would encourage you to have a very low threshold for delivery in moms that have worsening respiratory circumstances, respiratory failure for sure, and or worsening critical illness. Our experiences with these patients is that they have presented typically in the late preterm setting. The infection is very severe. They have rapidly increasing oxygen requirements from nasal cannula to face mask to high flow oxygen where you're on 12, 14 liters of oxygen, not functioning. And now the decision is intubation. And then are we going to take them to the intensive care unit while they're pregnant at 33, 34, 35 weeks? Or are we going to intubate, deliver concurrently, take the baby out, deliver the baby safely, and then focus all your attention on the mom? Most studies would demonstrate this is the safest circumstance to perform at 32 to 34 weeks, as we know that babies do quite well in the nursery at that gestational age. I love protocols, and we're going to talk about protocols coming up. COVID-19 protocol, I want you to take a look at this. I'm happy to share this. This is just something that I came up with in our own office and shared with all of our providers across the state. In November and December, New Mexico was inundated with COVID. We had hospitalizations, single diagnosis of COVID-19, 75, 80% of hospital beds occupied simply with patients with COVID-19. And this was no different in pregnant women. We utilized ICU doctors, we utilized hospitalists, we used intensivists, we used nurse practitioners, and this coverage of hospitalists and specialized COVID teams became overwhelmed. Obstetric providers, we're the first people bringing these folks on board to our facility, and we needed to be readily aware of how to grade the severity of their disease. We needed to know how to take care of them. We didn't want to delay. I didn't want to wait. Hey, as hospitalist, is it okay if I start Dex on this patient? Should I start remdesivir? Should we start oxygen? We developed a protocol. It helped guide us. It gave us good confidence. Doing something in an organization the same way, even if it's not perfectly correct, always is going to yield you better outcomes than random haphazard approach. So this is what we came up with. I'm happy to share it with you. The reason we did this is because we had relied on the initial assistance of our inpatient medicine service. Unfortunately, their response time was particularly delayed because they're taking care of other patients. So in order to assist OB providers to become much more comfortable with this, we introduced an algorithm, a checklist, a protocol, helped us grade the severity, direct our management, and streamline our care. And I think that that was a major important facilitation in how we avoided some significantly bad outcomes, particularly in the largest hospital in the state of New Mexico. Pay attention to that COVID-19 algorithm because we're going to see some other algorithms today. Let's switch a bit to that topic of preterm birth. COVID-19 is very interesting. It's led us to have higher preterm birth rates, and this is a topic we want to be familiar with as well. We have about 3.8 million pregnant women in the United States every year. 10% of them are born preterm. As you can see in this graph from the March of Dimes, our rate had been coming down, and then around 2016, that rate is slowly going up. Don't exactly understand why, but it is. Each and every state in the country has its own issues with preterm birth. Some of us do slightly better, some of us do slightly worse, some of us do particularly worse. And if we look at the inequity depending on our race and our ethnic background, these numbers may be dramatically different as well. Roberta Romero says preterm delivery has been and remains the most important challenge to modern obstetrics. I would completely and utterly agree with Dr. Romero, preeminent researcher in our field, who states that we should pay attention to this particular challenge. I am a dramatic and huge fan of Dr. Atul Gawande, checklist manifesto, how to get things right. We didn't know how to manage COVID-19, so we developed a protocol. It helped point us in a direction. It gave us encouragement because it's on a piece of paper. It seems valid, it's useful. Checklists, this book teaches us about how really to get things right and how in medicine we've had a dramatic experience with improvements if we will rely and put our hospital systems into the role of utilizing protocols and algorithms. I want to just share a really quick story with you from my friend, Dr. Atul Gawande. It's one of my favorite stories about why we should use checklists, and it really has an impetus from aviation. And we pay a lot of attention to aviation because in general, we have millions and millions of flights on an average year, but you have very, very few catastrophes. And so they must be doing something correct in aviation. I know it's of particular importance right now when you hear about the Boeing 737 MAX, and we're going to talk about a Boeing aircraft right now. So just reflect on this picture for 1 minute for me. In 1935 in Dayton, Ohio, the U.S. Army Air Corps was holding a flight competition for airplane manufacturers who were attempting to build the military's next generation long-range bomber. It wasn't supposed to be much of a competition because in early competition and evaluation, Boeing's gleaming aluminum alloy Model 299 had already trounced the designs of Martin and Douglas. Boeing's plane could fly faster, it could carry 5 times as many bombs, and it could fly almost twice as far. And a Seattle newspaperman who glimpsed the plane on a test flight over his city called it the Flying Fortress. The name stuck. According to military history, this competition of sorts in 1935 was really supposed to be a mere formality. The Army already planned to order 65 of this particular aircraft. So on this day in the fall, there was a small crowd of Army brass and manufacturing executives. They watched as 5 U.S. servicemen ran out to the aircraft and fired it up, smoke billowing out of the loud, grumbling engines, and then the plane taxied out onto the runway. Sleek and impressive, 103-foot wingspan, 4 engines jutting out from those wings rather than the usual 2. And the plane roared down the tarmac, it took off, climbed up to 300 feet, and it turned left, banking, at which time it stalled and came crashing to the ground. Major catastrophe for Boeing. 2 U.S. servicemen died, and we don't know what happened. This airplane was so complex. It's the greatest technological achievement of our day in aviation. There was no NTSB from the FAA at the time, and so we did do an investigation on this, and people thought about it, and Boeing, as they historically have done, have put incredible amounts of research into why something bad happened. And I might ask you, what do you think happened? Why did this catastrophe with perfectly trained U.S. military pilots, I mean, what did they do wrong? Was there, something mechanically wrong with this complex plane? Was there not enough gas? I mean, in the end, when you have something complex, you want to try to simplify it. When we're caught up in chaos and pandemonium and fear and anxiety, we want to rely on something. And these individuals, they forgot one simple step. They knew how to fly the plane. They're actual experts at it. They forgot to take a little metallic clip off of the flaps on the wings. Those flaps are incredibly useful because you need the flaps to be able to turn and ascend and descend. Without that, you stall and you come crashing to the ground. In 1935, we didn't have checklists. These checklists that we all are so familiar, and thankfully pilots rely on them. That's why we have such amazing achievement in aviation with so few errors. I love this checklist from 1944. It's just a reminder, you know, before you even start your engine, use the checklist in the cockpit of your airplane. No matter how familiar you are with your plane, there's always a chance that you'll forget something. Do not rely on your memory. Always use a checklist. Take a look in this airplane. This is the B-17 Flying Fortress. Crazy, so many dials, so many knobs, got a giant steering wheel. This plane's very complicated. But with Boeing's introduction of a checklist after this 1935 catastrophe, this single aircraft was flown 1.8 million times in World War II without another incident of human error. And so the power of just putting something down on paper to guide individuals that have all varying experience, maybe they had a rough day, maybe they didn't get enough sleep, maybe they're anxious, maybe they're concerned. But with the checklist, they achieved a great success. And we should do the same thing in medicine. This is kind of our cockpit, you know, in the evaluation of preterm labor. We can talk to patients. Just getting out of a patient that she has suffered a prior spontaneous preterm birth. Maybe she delivered her baby at 28 weeks. Profound risk in her next pregnancy to do the same thing. And we should be well aware of that. You have to talk to the patient to get that history. I know it sounds funny, but as an MFM doctor, very frequently get transport phone calls for maternal transports for preterm labor. And I ask the patient, ask the doctor who's calling me, tell me a little bit about the patient. And you can hear the hesitation in their voice because they actually didn't ask the patient about her obstetric history. We can check out the patient's symptoms, whether or not she's contracting, is she having any vaginal bleeding or spotting. Physical examination, critically important. Search, assessing that cervical dilation. Is she 6 or 7 centimeters dilated? Clearly in preterm labor. We can use an objective biomarker test called a fetal fibronectin. We can use an ultrasound. I love ultrasound in maternal fetal medicine. We do a lot of it, transvaginal ultrasound, to assess the cervical length. But you know, determining who's actually at risk of spontaneous preterm birth is quite challenging. Of patients that are hospitalized, that I put in the hospital for a diagnosis of preterm labor, I'm only right 50% of the time. And of the whole cohort, any patient who has symptoms of preterm labor, who shows up at 2 in the morning to your obstetric triage unit, actually less than 10% of those folks will deliver within a week. So the great majority of those patients do not need that hospitalization, and nor do even the patients that I hospitalize need that hospitalization. But we have to actually figure out who's truly at risk. We can use a variety of tools. This is a chart just showing relative risk for spontaneous preterm birth less than 32 weeks, early preterm birth, kind of more harmful preterm birth that we want to avoid. We love contraction activity, but contractions are actually a very poor predictor of whether or not the patient is going to deliver preterm. Vaginal bleeding only increases the a priori risk by about 2.5 or so. That history, if she tells you she's had a baby preterm before, that's profoundly powerful. 6-7-fold higher risk of a preterm birth in that patient. If she has cervical shortening on that vaginal ultrasound, much higher risk. If she has a positive fetal fibronectin, her a priori risk is increased 14-fold for having a spontaneous preterm birth, something to reflect on. But we really don't care. You know, I mean, she's there at 26 weeks. She's contracting. She's having pelvic pressure. She's having some irritability. She's having some pelvic discomfort. Her back hurts her. You know, all kinds of these sneaky symptoms for preterm labor. We really want to know, is she going to deliver in a week? Because that's the time we need to get her steroids so that her baby does better, because we know antenatal corticosteroids are profoundly helpful. We want to maybe admit that patient for magnesium sulfate. So we want to know, you know, what do we need to do with that patient in the next 7 days? How well do things predict outcomes? And so our PPV is important in that realm to kind of tell us should we do things. And the NPV tells us that we should be able to send that patient home safely. If she's contracting, again, you can see the PPV, or positive predictive value, is really, really low. So while contractions, we get very excited about them. Yes, they're interesting to see on a monitor. They're a very poor predictor. Is that patient going to deliver in 7 days? Whether or not she's contracting is not very probable to predict outcome. If she's dilated 1 centimeter or more, even 1 or 2 centimeters, only 30% of those patients are going to deliver in a week. If she has a short cervix, similarly, about 25% deliver. If she has a positive fibronectin, and then this is how kind of using 2 tests is extremely useful. So we use 2 tests in a lot of areas in medicine. In obstetrics, we do something called sequential screening. We do a first trimester lab draw, we do a second trimester lab draw, and then that predicts Down syndrome. And if we use 2 tests, that's actually really useful. Another example in medicine, if you have a patient who shows up in your ER and has chest pain, what 2 tests might you use? You might use troponin, you might use an EKG, bioelectric test, a biochemical test. You put the 2 together. Abnormal EKG, high troponin, go into the cath lab because we're having a heart attack. Similarly, positive fibronectin, a biochemical marker for preterm birth, as well as a short cervix, put the 2 together and look at the positive predictive value. Almost 65% of those patients are going to deliver in a week. Those are the patients we should be focusing on. Objective test, fetal fibronectin, collected, it goes to a lab, you get a test that's positive or negative. Cervical length, need training, can be very variable, and we need training to do it because science has told us that. When we look at the Society for Maternal Fetal Medicine, and they help us understand through the Cervical Length Education and Review, or CLEAR, this is an organization that at any time, if you think you want to do transvaginal ultrasound in your facility, these people need to be trained. The reason they need to be trained is that a lot of us don't take the pictures correctly, nor do we measure the cervix correctly. The SCAN trial, 15% of images were not correctly taken. New mom to be, the cervical length was not measured correctly in up to 1/3 of patients. That's not very good, because that's not providing great care to that patient. Maybe you inaccurately reassure yourself with a nice, long, normal cervical length, but actually you're not measuring it correctly. Maybe you didn't wait the 3 to 5 minutes that's necessary to see that cervix might shorten. And even when we go through the testing, about 20% of the time, so I am certified by CLEAR. You have to submit images for review. You have to take a test. It's not particularly difficult, but it shows that you're trying to achieve higher standards of care by doing this. And 20% of us flunk that test in the first time. So clear evidence that we need to be trained in how to do this. Cervical length always should be transvaginal, 75% of the image. Look at the anterior, posterior width. The maternal bladder should be empty. The bladder can push on that cervix, make it look abnormal. And we always want to put that caliper correctly on the internal and external os. And then we need to make sure we look for mobility of the cervix. What does that mean? I mean, so what do you think? Is this cervix normal? Looks pretty good to me. It's nice and curved. Use 2 measurements. Always use 2 straight lines or 1 straight line. Don't curve a linear. Measure this. This 2.2 plus 2.6, 4.8 centimeter cervix. Completely normal. How long are you supposed to wait when you're taking those pictures of that cervical length? Should you just get in there, take 3 pictures, bam, 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 really quick? How frequently do contractions come? Usually they come every 2 minutes, every 3 minutes. So maybe this is picture at minute 1, then we wait minute 2, minute 3, and then a minute 4, or minute 3, as the slide says, funnels down to 5 millimeters. This is profoundly abnormal. I was telling you, this looks perfect, but if we hadn't waited the appropriate amount of time, which is at least 3 minutes, 5 minutes better, looking at the cervix, you are going to miss this. And we're going to miss an opportunity to identify this patient by using just vaginal ultrasound. So why using 2 tests always better if you have the opportunity to have that circumstance. Biochemical test, fetal fibronectin. It's a glycoprotein. It's found between the amnion and the chorion. We call it a glue. And it really helps us to predict, is preterm birth imminent? because it spills into the vagina when there is an issue. And it should not be identified in the vagina from about 15 weeks to 36 weeks. It should be absent. And if it's showing up, that is distinctly abnormal. This test was specifically designed and approved by the FDA because it has a high reliability to rule out preterm birth in symptomatic patients. A negative result means that the patient has a less than 1% chance of delivering in 14 days or 2 weeks. So if it's negative test, we probably don't need to admit them. We don't need to give them magnesium sulfate. We don't need to give them steroids, because the probability of delivery in that time frame when those medications would be of benefit is close to 0. And of all those patients that show up in our triage unit, an interesting number to remember is if we collect an FFN on every single one of them and send it to the lab on every single one of them, 80% of them are going to receive a negative FFN result. Pay attention, please, to the 80% number for me, because we're going to talk a little bit about that and how important maybe offering this particular test to all pregnant patients that have symptoms of preterm labor is particularly important when they show up to your triage unit, or they call you and you want them to come to your office and you collect this in your office. The specimen is always collected with a speculum, ideally. This picture, you can see the speculum in the posterior fornix, 10 seconds. It absorbs the cervical vaginal secretions. You want to get a good specimen, and then you send that test to the lab after you click the top of the shaft off and place it into the bottle with the buffer. We are not testing the Dacron-coated little swab. We're testing actually the liquid, which has the glycoprotein fibronectin in it. And you put the cap on carefully so that the contents do not spill out of the cap, and then please send that to your laboratory. The FDA has approved this for symptomatic patients from 24 weeks and 0 days to 34 and 6. Really important to pay attention to that 34 and 6, because the 34 and 6 time frame, maybe that's time we could give them late preterm steroids, 34 and 0, 33 and 2. Cervical ink becomes a little bit less pertinent after 32 weeks. Also can be done in asymptomatic patients from 22 and 0 to 30 and 6, but we're going to focus on those symptomatic patients. We want to collect the specimen prior to any digital cervical exam. Why? Because putting your fingers in the cervix for a digital examination may prompt release of fibronectin and lead you to get a false positive result. You want to also avoid placing the Dacron-coated swab right into blood, because blood has fibronectin in it, and that may also yield a false positive result. If she's dilated 5 centimeters, we already have our answer, so this test is not useful. It's useful at 0, 1, and 2 centimeters. Greater than 3 centimeters, we have advanced cervical dilation. It should not be done. Don't put the swab right into a big clump of a cream like progesterone, because it may not absorb the fibronectin, and you'll have a false negative result. Thus, may be useful to look with speculum. And then there's often controversy about sex and fibronectin. If the patient's had sex and shows up in labor and delivery with contractions, fibronectin definitely still can be utilized. If the test result is negative, it is not detecting any FFN specimen, and the predictive ability of the negative predictive value is still valid. 99% of those patients will not deliver in 14 days. If the test is positive after a patient has had intercourse, then we need to reflect on that and think that that very likely is a false positive result. And maybe we wait a little bit of time to look at that and repeat that test. All collection kits are free. The patient only receives a bill after the FFN test is actually done. And I would tell you that the cost of this is inexpensive in relationship to anything that we do in medicine, very similar to many, many things that we do, and may help avoid some tremendous costs to the patient if we inadvertently admit the patient to the hospital. What we do and how we identify all of these pregnant women in triage. Number one reason a pregnant woman shows up in the United States for OB triage visit is preterm labor. And we want to identify those folks that are at that greatest risk of actually having an imminent spontaneous preterm birth, because we want to give them magnesium sulfate, which protects the fetal brain, prevents cerebral palsy. We want to give them antenatal corticosteroids because it profoundly improves respiratory distress syndrome outcomes. And that identification of that positive fibronectin might identify that we need to get that patient out of maybe one of my small towns in New Mexico, Tucumcari, Roswell, Taos, New Mexico. Great skiing, but very, very small hospital. Doesn't have a level 3 or level 4 NICU. And so we want to transport those patients to give that baby the best possible outcome if they actually are born preterm. Every intervention we do in medicine has a cost too. If I admit a patient just for 48 hours to our hospital, at least $4,000, put them on an IV, give them magnesium sulfate, steroids, nursing care, doctor care, and a hospital bed in the hospital, at least $4,200. If they are flown to me on a fixed wing aircraft or a helicopter, that bill today is going to be about $35,000+. While very exciting, I love flying in helicopters. If I can sweet talk these pilots into giving me a ride, it's very, very expensive, and it's an incredible cost to our patients if they don't need to incur that emergent transport. We do, though, want to be very, very careful about getting these patients transferred to us carefully, because the outcomes when they're in bigger hospitals, these babies do better. And if they're in small hospitals, they do worse. And this is a study from Canada that's showing exactly that if we accidentally miss one of those high-risk patients and they're delivered in a small hospital, their death rate is actually twice as high. Their respiratory distress rate is also twice as high, and their difficulties with bleeding in the brain is markedly higher. Why do we have trouble with this in obstetrics? I guarantee if I asked you in an audience that was live, and I asked somebody on the West Coast, somebody in the Midwest, somebody on the East Coast, do you have difficulties with this? It's going to be because we have doctors and nurses and midwives that all think we have autonomy. We know the right way, and this is what we're going to do. We also have really little oversight and enforcement in medicine. People come from different areas with different training and experience. I learned this method and I learned X method, and my method's better. Some obstetricians are really concerned. Some midwives are not concerned at all. We'd have different levels of concern on labor and delivery. And unfortunately, we also have some conflicting research, which leads us often to a lack of an established standard of care. But I want to show you some research, because I think actually in this area, we do have a pretty significant standard of care that we should adhere to. Our professional society, at least as an obstetrician, the American College of OB/GYN, wants us to do a better job in the realm of putting protocols and checklists in place. Just like we put a COVID-19 protocol in place, we need to look at the most common thing that goes on in labor and delivery, and that's preterm labor triage. And OB/GYNs, as an ACOG member, we should help be doing this process by improving and adhering our guidelines and protocols in our facilities. This process is complicated. It has to have a huge team. We need to train individuals. We want to collect data, show that we're doing outcome improvement by placing protocols in place. And if they're not doing improvements in outcomes, we need to adjust our protocols. Our midwives and our nurses on labor and delivery don't get out of this call to action either. The ACNM has a position statement on prevention of preterm labor that states that any woman with preterm labor contractions, FFN testing should be used. Cervical measurement techniques should be accessible. And in A1, they say that checklists, that last bullet point at the bottom, checklists and standard order sets should be used. So what would your protocol look like? Let's not reinvent the wheel, because there are other protocols out there, but we can assess their clinical history, talk to the patient, put them on the monitor, do an exam. But maybe before we jump right to that examination, we could consider doing a transvaginal ultrasound if you have a clear certified individual in your facility that knows how to do this measurement. And then ideally a laboratory test that's readily available across the country in most hospitals. Fetal fibronectin gives us a yes or no answer as to maybe what to do with that patient. If we walk through an entire protocol in our facility and we had a negative evaluation, would that be a benefit? I love rounding on patients. If it's Saturday or Sunday morning, I hope we have like 20 patients there. I love saying hi to a bunch of pregnant ladies that have been admitted for preterm labor. They're sitting calmly in their bed. I'm actually being kind of facetious. Pregnant people, just like normal people, they don't want to be admitted to the hospital. They have lives, they have jobs, etc. If we do a proper evaluation and we don't admit them, maybe we actually could decrease our maternal admissions. Maybe we can make our triage length of stay faster, decrease that. I could avoid firing up that helicopter if they have a negative fibronectin, normal cervical length, they're not contracting, they're not changing their cervix. Maybe I could save money for the actual patient, our healthcare system overall. Maybe we could provide some really good emotional and social benefits for the patient. Patients are very keen, they pay attention to us. They start to question us, though, when you tell them that they're 2 centimeters dilated, and then 2 hours later, somebody tells them they're 1 centimeter, and then somebody 3 hours later after that tells them that they're 0.5 centimeters. it's kind of weird. Like the cervix is open, then it closes, then that doesn't seem right. If you give them a good evaluation with a negative fibronectin, a normal cervical length, you can tell them that they have a 99% chance they are not going to deliver preterm. They are less anxious with this, and I see that in my work every day. But if it's positive, then actually we can intervene on those high-risk patients. So if they have a positive fibronectin, we know that that's an abnormal marker. It shouldn't be there. If they have a short cervical length in conjunction with that, huge risk of delivery within 7 days. There's studies that support this use of a protocol. I showed you our COVID-19 protocol. These are protocols in medicine about preterm labor evaluation. One from the Mayo Clinic's one of my favorite, cost-effective standardization of preterm labor evaluation. Done over a year. They changed the way they triaged patients. And I showed you our COVID protocol that helped us improve our outcomes. Here's a protocol in preterm labor triage. If they're contracting, put them on the monitor. Take their vital signs. If they're 5 centimeters dilated, obviously, we admit the patient to labor and delivery. If they're not, at Mayo Clinic, they had well-trained individuals, and so they were using cervical length. If they had an equivocal cervical length, they did send an FFN. If it was negative, they trusted that and they discharged the patient home. If the FFN was positive, though, in this kind of gray zone of 15 to 30 millimeters, then they trusted that test and admitted the patient because that was a sign of something abnormal. They implemented this protocol. Their OB residents were forced to do this by Bill Watson, the chairman. And the performance of the protocol was really quite incredible. If followed, 99% of patients did not deliver within 7 days. If at 14 days, 98% of patients remained pregnant. They reduced their preterm labor admission rate by 56%, and they saved money. And they made the protocol an algorithm which showed improved outcomes, a formal policy. And then they did a cost-effective analysis and said, hey, this actually saves us in the country a huge amount of money, like $500 million. Here's a study by Amin Ness and Dr. Bergeliff, very famous names in the realm of preterm labor research. This is a randomized study. They wanted to know if the knowledge of a protocol helped versus if you didn't have knowledge of the protocol. But their goal was actually to see if it decreased the time of triage. But there's some interesting things with this study. So another algorithm, just like our COVID-19 algorithm, here's an algorithm about preterm labor, very similar to the one that was done at the Mayo Clinic. They randomized 100 patients, 50 in the knowledge group, 49 to standard random haphazard management. They were really, really fast in triage here. And so 2.2 hours versus 2.5 hours here. So 2 hours and 24 minutes, 2 hours and 49 minutes. The mean time difference was not statistically significant. So they said the study actually wasn't of benefit. But the really interesting thing is that in the knowledge group, when we know that patient's fibronectin's positive, when we know they also have a short cervix, and we treated them with mag sulfate and steroids, their preterm birth rate was lower, 13% versus 36% in the random group, a reduction of preterm birth of 63%. Kind of weird. This was not anticipated. This is just a slide showing that scenario. Of the people where they actually knew about the protocol and followed the protocol, these patients actually stayed pregnant much longer, 66 days from evaluation versus 49 in the random haphazard group. The significant reduction in preterm birth in the knowledge group compared to the standard group was unexpected, but it was distinctly statistically significant. And they've always said that this requires larger evaluation. And I hope maybe one of you in the audience might actually take that impetus and do that study so that we can actually have some really solid evidence from a randomized controlled trial that protocols in preterm labor actually function. My belief is that they do, but that would be a wonderful study to present. This is an example of a protocol we would suggest to use for preterm labor. Admit the patient, take her vital signs. Don't forget to do that urinalysis, collect the fibronectin and send it. Don't forget to do STI evaluation, gonorrhea and chlamydia, trichomonas with that. GBS evaluation. If they are leaking fluid, don't forget to check them out for PPROM. We'd suggest that before you collect that cervical examination or do that cervical examination, that you send that fibronectin. If they're under 3 centimeters dilated, use the fibronectin to guide you. If it's negative, they can be discharged home. If the fibronectin's positive, this is where that cervical length, if you have a clear certified individual that knows how to do a cervical length, then I would suggest using it. If it's abnormal, then we need to talk about, now we have positive fibronectin, now we have a short cervix, now we need to admit that patient because they have a tremendously high risk of preterm birth. This realm of research in this topic, just like COVID, is growing dramatically, not quite as rapidly and exponentially, but just fibronectin, 2,800 articles about that glycoprotein. And when you combine FFN and preterm labor, 544 articles, huge amount of information. This is a study by Duda, nice systematic review, looking at all of the studies about implementation of a protocol that uses FFN to guide management. And you can see all of the statistically significant measures that decrease length of stay, decreased transfer of care, and this is in Australia. Montreal, Canada, decreased admissions, decreased length of stay. How about in the United States? Decreased length of stay. Here's a study by Swami, decreased hospital admissions, actually decreased use of unnecessary antenatal corticosteroids and tocolytics. Profound benefit by following a protocol and trusting laboratory testing that tells you that it's negative and the patient has a low risk of preterm birth. How are we doing about this in the country? This is a very interesting study by Sean Blackwell, one of our other former presidents of SMFM. 23,000 patients in an insurance large database, 5 representative states throughout the United States. 23,000 women that show up in our obstetric triage units. 24% of them are admitted. Those are people in preterm labor, obvious, and they manage those patients. We, OBGYNs, MFMs, certified nurse midwives, family practice doctors, OB residents, family practice residents, labor and delivery nurses, we discharge home 3/4 of these people. Your sister, my daughter, who's pregnant, who's contracting at 28 weeks. We discharge 76% of them. The majority of them will do okay, 80%. 20% delivered, though, within 3 days of your discharging them out of the hospital. This is not an inconsequential number. 1 in 5 of patients that you discharge home will return to labor and delivery and deliver their baby in 72 hours. I told you to remember these numbers. 80% of patients will receive a negative fibronectin. So here's that 80%. If we had done an FFN, we would have known these people are safe for delivery. These very likely could have been identified with a fibronectin that was positive, because 20% of fibronectins in general are positive. That would have given us a warning sign on our dashboard. Hey, that's the patient I need to pay attention to. Maybe I give her magnesium sulfate. Maybe I give her steroids. But what actually happened to this group? The 20% who returned and delivered, how were they actually evaluated? 80% of them had no biochemical test called fibronectin done to them. 80% did not have a vaginal ultrasound, which we've shown has been beneficial if you know how to use it. The combination of the two, kind of the best outcome of cervical length and a fibronectin done, only 1% of that population had that testing done. 3% had a fibronectin done. So basically, we are missing the boat in the United States on this topic, and we need to do a better job. This could be your family member, your sister, your daughter, your spouse. How do you want them evaluated? Do you want a completely haphazard approach where maybe they get a cervical exam, maybe they get placed on the monitor, maybe they get a urine culture? No, you want them to get everything done, a complete, thorough evaluation. That's what they deserve, but we're not doing it. This is a very recent study published in 2017. My suspicion actually now during the pandemic, I bet you this is worse because we're so hyper-focused on other things, obviously. We need to pay attention to our protocols. How else can we help these patients? We need to not forget how to use preterm labor protocols, but we also have to remember that we need to screen them for sexually transmitted infections. That's part of our protocol for preterm labor. The CDC is telling us, the Department of Health and Human Services advocating, we're not seeing patients in person anymore, and we're not screening them for STIs. We know sexually transmitted infections have a very strong link to preterm labor, PPROM, lots of different complications in pregnancy. Pregnant women infected with chlamydia were twice as likely to have a spontaneous preterm birth and 3 times as likely to have an early spontaneous preterm birth. So why we recommend checking them in your institution. Is every one of those patients checked for a chlamydia infection? Our cases of STIs in the country are rapidly rising. Studies since 2014, 19-20% increase in chlamydia, 63% increase in gonorrhea. Something to remember, very important, causality to preterm birth. We need to not only use our tools to predict the outcome, but we also need to test for the causes, do our urine cultures, do our STI evaluations, and we're likely not doing that. The way we're supposed to do this based on ACOG recommendation is nucleic amplification testing, trichomonas, chlamydia, gonorrhea, best checked by NAT testing. Our Aptima test for Trichomonas vaginalis detects up to 100% of these infections, and it's recommended not only by ACOG, but also the CDC. These are kind of our current pregnancy guidelines that I think we often forget. If you're under 25, definitely should have screening for chlamydia at their first prenatal visit. If you have any risk factors, we should be doing gonorrhea testing as well. I'd advocate this should be universal because when you start to look at these things are very, very common. We should retest in the 3rd trimester. These are CDC recommendations. I honestly don't see very many pregnant women being tested for chlamydia and gonorrhea if they meet these criteria in the 3rd trimester. We're now doing glucose, CBC, and syphilis. We need to remember to throw our STI testing in that realm as well. And if any patient has a positive test during pregnancy, make sure we do a test to cure after their treatment. But I don't see people getting tested within 3 months. They're not getting retested. And that's just my experience. I'd ask you to reflect on what your experience is. These infections are often undertreated. Maybe they're not treated. Maybe their partner reinfects them. So we need to make sure we're retesting within 3 months as well for all of these patients that have a positive gonorrhea or chlamydia test. Aptima multi-test swab allows us to look for all of these entities. We can check for trichomonas, gonorrhea, and chlamydia. Why the pertinence of this talk that combines a public health crisis, preterm labor, COVID-19? Why are we talking about this? We want to limit the number of admissions of any type of patient to our facilities. We are inundated by COVID-19 patients. We have ambulance crews telling patients not to transport individuals that have little chance of survival. Our society, our hospital situation, our healthcare facility is at its max capacity. We have limited bed space. We have high stress environments. We need to be following protocols in how we manage COVID-19. And we definitely need to be using protocols in each and every one of our available tools to identify those folks that present with the most common reason they're going to come to an obstetric triage unit with preterm labor. Please take away from today's talk that a negative fibronectin tells you that there's less than a 1% chance that that individual patient in your triage unit is going to deliver in the next 14 days. If they have a negative fibronectin, there's no indication for treatment and they can be reassured and discharged home. And 80% of them are going to receive that negative test. And importantly, like in Dr. Blackwell's study, 20% of them are going to have a positive test. And those are the individuals, based on that huge study, that we really need to focus on because they're the ones that are very likely to come back and deliver. I started with Dr. Gawande. I'm a big fan of his, had a chance to meet him in person recently at the ACOG meeting just last year, or excuse me, 2 years ago. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists. We pay little attention, though, how to make them fit together well. When we look closely, we recognize that the same balls are being dropped over and over, even by individuals with great ability and determination. We know the patterns, we see the costs. It's time to try something else. Please try a checklist. Huge fan. I can't promote Dr. Gawande's book enough. I don't have any association with it from an economic standpoint, but it was tremendously beneficial to me as a physician and how I look at medical practice, and I'd really encourage you to take a look at it as well. Again, one more plug for our 2021 educational webinar series. Please check out Dr. Brian Urier in April, Dr. Cynthia Giampi-Bannerman in June, and Drs. Andre LaBarber and Dr. Fox in August. And I'm going to end there, and I would be happy to take any questions that you have.
Thank you so much, Dr. Ruma, for that great presentation. As a reminder, you can go ahead and submit your questions using the Q&A button that's at the bottom of your screen. And thank you to everybody who has already submitted questions. And one of the biggest questions we've received is, will these slides be available? And everybody who registered for today's webinar will receive a recording of it. All right, Dr. Ruma, if you want to stop sharing your screen, that way folks can see you a little bit bigger on there. We will go ahead and get started with the questions that we have received today. So first one being, how long does it generally take to get FFN results?
I would say it depends on how well you have your system set up. Anytime we're putting a protocol or checklist in place, we want to walk through the process. We collect a specimen, we order it in a computer, and we send it to a laboratory. The sending to the laboratory is always a time frame that has some delay in it. So if we have a way to expedite getting that to your laboratory facility, and then obviously it has pertinence to how the patient is going to be treated. So I would encourage that to be ordered as a stat, not routine test. So you're getting a rapid turnaround result. And maybe you even talk to your laboratory where that lab could contact you verbally and say that result is negative. That really provides us the greatest efficiency. The lab test itself takes less than a half an hour to run at the bench. It is a very simple test to run, and the machine that runs it takes about 20 to 25 minutes to give you a result that's positive or negative.
Okay. At what EGA does your practice no longer utilize cervical length? We train to stop performing them at 23 weeks, 6 days, and convert to clinical cervical exam.
So two circumstances when we're looking at cervical lengths in obstetrics. There's the asymptomatic population, and then there's the symptomatic population. If you read Dr. Cynthia Giampi-Bannerman, if you read Dr. Sonia Hassan's article, 2011 UOG, that talks about vaginal progesterone and that's used to prevent spontaneous preterm birth in patients who have asymptomatic cervical shortening, that's when 18 and 0 to 23 weeks and 6 days is useful for prediction of spontaneous preterm birth. If it's less than 20 millimeters, those patients should get vaginal progesterone to prevent asymptomatic patients from delivering preterm. If you have a symptomatic population, I would suggest cervical length is beneficial really from 18 and 0 if they have any pelvic discomfort, any pressure, any pain, preterm labor symptoms. Really, cervical length very important because you might identify that they need a cerclage based on that. But the upper limits, 32 weeks and 0 days, the cervical length tends to not be predictive. And the reason it's not predictive is because the cervical length tends to shorten over time. Mean cervical length in the mid trimester of pregnancy around 20 weeks is 38 millimeters or 3.8 centimeters. That number decreases over time. So as we enter into the third trimester at 32 weeks, they're almost all going to have a cervical length, which we think is short. So thus the critical importance of using that fibronectin test in all of those patients.
Okay, we have a couple of questions here. One says, the presenter said COVID-19 has an approximate 1.7% death rate in the general population. What is the death rate for pregnant women?
Yeah, varying statistics. So that set net jurisdiction study is the one that we're leaning on to get this a priori and this kind of odds ratio. And that difference is 1.5 and 1.2 per 1,000 people. A standard odds ratio that's come from that study and others, and you have to realize these studies are continuing to be added to. They're all giant systematic reviews, and the aggregate number of patients now is in the 50,000 realm. We believe that the risk of death in patients is twofold higher if pregnant with COVID-19 versus non-pregnant with COVID-19. And so pregnant women distinctly have a higher death rate. They have a higher ICU admission rate that is at least threefold higher, and they have a higher intubation and mechanical ventilation rate.
Okay. Second question says, the presenter said less than 10% of preterm labor patients will deliver within a week. Does this statistic include Preterm labor with PPROM.
It would be aggregate, yes, all of those individuals. If a patient shows up in your triage unit and has confirmed preterm premature rupture of membranes, PPROM, or now what we call pre-labor preterm rupture of membranes, that scenario with a confirmed diagnosis of PPROM, those patients have a tremendously high rate of preterm birth. That's why we recommend they stay in the hospital. 50% at least are going to deliver within a week, and that number continues to grow for every day that they remain pregnant.
Okay. This is a little bit of a longer question, but I'll read it. Are you giving every COVID positive pregnant patient anticoagulation or just those with severe symptoms? We have had a debate amongst our OB group about who to anticoagulate. One of our OBs feels that because there are so many asymptomatic COVID positive patients out there, wouldn't we be seeing VTEs as almost a presenting COVID symptoms in many pregnant women?
Yeah, so even my colleagues in MFM, so it's not just your OB colleagues, debate why we want to use protocols. Following a path tends to, making a decision and committing to it tends to help us do better than not. When a patient's hospitalized with COVID-19 and pregnant, all those patients should be on prophylactic anticoagulation. The CDC up-to-date ACOG, OB articles are suggesting that when discharged from the hospital, that prophylactic anticoagulation can be discontinued. So I don't think that every asymptomatic positive patient that's at home, those individuals don't have to have anticoagulation. Now, that said, if you have a patient who is critically sick, maybe in the ICU for 2 weeks, then she was in a recovery unit for a week or two with you in the hospital, and now she's gone home, and maybe she's has a BMI of 50 and chronic hypertension and diabetes, and she's going to be sedentary at home, and that patient, maybe you might have a lower threshold for that individual to continue it. But in general, asymptomatic and even symptomatic positive COVID pregnant women at home, they do not need heparin anticoagulation, only when they're hospitalized.
All right, we've got a few more questions here. Do you think nutrition can prevent preterm labor, specifically a whole food plant-based diet? This could help the healthy gut microbes.
I think yes, like many things, if we exercise regularly, eat healthy, don't smoke, practice good, behaviors, and certainly seems to be of significant benefit. I don't know specific literature about a plant-based diet. One of the biggest studies on preterm birth prevention, the New England Journal of Medicine 17P study, they paid attention to some dietary intake. Actually, women that ate more fish tended to have longer gestations. We don't really know why that is, but yes, certainly maybe a healthy diet, I would argue, would be a benefit.
All right, and this is a question that was actually submitted before during registration, so I think you've kind of talked about this, but good to reiterate. What is the role of fetal fibronectin? I am working at a new place, and they seem to use it all the time.
The role, I think, is that the test specifically, this test has been FDA approved for a long period of time in the United States. Anything in medicine, it takes time to get to be used, and then we start using things a lot, then we start to forget about things, and why kind of talks like this are very beneficial to rejuvenate and renew our knowledge base so that we're actually doing the right thing. Fetal fibronectin specifically acts as a great rule out test that tells you as the obstetrician, labor and delivery nurse, midwife, family practice doc, OB resident, you don't need to do anything to that pregnant patient who's having symptoms of preterm labor if the testing is negative, because less than 1% of them are going to deliver in 2 weeks. What you can do for the patient with that result is tell them confidently, compassionately, decrease their anxiety. You're having what we might call Braxton Hicks contractions, false labor, preterm labor. It's not actual cervically dilating. You're not going to deliver. This test gives a strong predictive ability so we can confidently discharge that patient and they don't need care in the hospital.
All right. This is an interesting question. There has been some concern from our pregnant moms that take Tylenol with vaccine admin. they are hearing that Tylenol is decreasing the effectiveness of the COVID vaccine.
Yeah. COVID vaccine studies, the Pfizer and Moderna study, why they're saying not to pre-medicate is that the studies didn't do that. And so we don't have an answer, yes or no. Is there an effect of pre-medication, Tylenol or Benadryl or Claritin or any random medication before a COVID vaccine? So when we look at studies, just like I'm showing you a lot of preterm labor studies about fibronectin, cervical length, why you want to use fibronectin in every preterm labor patient, by following a protocol, you have a better outcome. I'm telling you to mirror what the research studies showed. If you follow the exact guidelines of the research, you're going to see those outcomes most likely. So if you're going to get a COVID vaccine, the people that participated as study participants for Pfizer and Moderna, they were not given pre-medication. And so that achieved those 94, 95% high efficacy levels. They were allowed to post-treat if they developed side effects. And so we really, as humans, we want to replicate what the studies did. And that's why you're hearing this controversy about pre-Tylenol usage. I would encourage you not to do it. I've had both of my vaccines personally. My first one, I hardly noticed. I got the Pfizer vaccine. The second one I got 3 Thursdays ago. And I barely noticed that. 20% of people will have armpit tenderness from a little lymphadenopathy. I had that. It lasted 2 days. I took a Tylenol after my second shot. I would encourage you not to pre-medicate.
Okay. Does using lubrication on a speculum to collect the FFN affect the accuracy of the test?
I would tell you no, because you're not putting the Dacron's swab anywhere near that. Around the country, I would encourage ideally to utilize a speculum, but around the country, this is really quite split. You can put the FFN specimen or collect the FFN with the speculum. It's great because then you can see exactly where you're putting the Dacron coated swab. You're not going to touch any lubricant and it's not going to absorb a large amount of that. Posterior fornix, 10 seconds, send the lab to the laboratory for the actual result. Even blind collection, so no use of a speculum. This is an off-label FDA use, but there is research to demonstrate that even if you placed it blindly into the vagina, that test result is an accurate and comparable result. So that's the long and short of it.
Okay. We have about 8 minutes left, so go ahead and still continue to submit those questions, but we have a couple of more. When you do the test in your office, I guess for FFN, do you also test for STIs at that same time?
So if a patient's presenting with symptoms of preterm labor, I would say yes. And I think it's important. These are the causative reasons. It's the same reason we ask a patient to urinate and give us a urine specimen every single time they come in the office. She's having symptoms of preterm labor. Urine culture abnormality may cause that. An STI may cause that. And just regular old-fashioned preterm labor may cause that. Why we want to do a urine culture, why we want to do an STI test, why we want to do a fetal fibronectin. I really love doing this workup in the office. Patients face a big insurance copay when they come into the hospital. Our patients have told us that every time they show up in triage, they're getting a $500 copay bill. I'd much rather serve them in the office, more comfortable, faster, easier. So Monday through Friday, 8 to 5 when we're open. If a patient has symptoms of preterm labor, I have them come in. We collect a fetal fibronectin, we send it to the laboratory. We also look at the cervical link. We use the 2 tests in conjunction. If they're abnormal, then they go to the hospital. If they're normal, they get reassurance, they go home, we follow them up in the office. Can't tell you how much office evaluation is a benefit to your practice. Your patients will love you because they're not having to go to the hospital. So big benefit of trying to do this evaluation in your own offices.
All right. Would you clarify what is the latest gestational age for FFN testing?
Yeah, so the FDA says that the upper limit of that is 34 weeks and 6 days. We had a question earlier that cervical link's really not so useful after 32 weeks. So from 32 and 0 to 34 and 6, when these patients show up with contractions, the FFN really stands as the only and best test to evaluate these patients. So please collect it on all of them. It's very common that we kind of forget to do anything after 32 weeks. The reason is why. I mean, I don't know why. Yeah, the baby's going to do okay, but it would be great not to admit these people unnecessarily. So at 34 and 6, if that FFN's negative, great, they go home. But if it's positive, what are you going to want to do to that patient? We don't need to use mag sulfate anymore because that baby's not going to benefit from mag sulfate for neuroprotection, but they are distinctly going to benefit from betamethasone. And so that 34 and 6 positive FFN gives us a great opportunity to give that patient betamethasone to help that baby if the baby delivers preterm.
All right. With the fetal fibronectin test, what patients should we be doing this to? Or should it be routine for all preterm patients that come through OB triage? I think you've kind of talked about this before.
Yeah, can't reiterate this. And these are good questions. Don't overthink things. We follow the KISS principle. I try to, keep it simple, stupid. We are not great predictors of outcomes. Diabetes screening in pregnancy. She may be a perfectly slender plant-based diet lady, and at 28 weeks, you'd never guess that she has gestational diabetes. But what do we recommend? We do a glucose tolerance test on all pregnant women. Why? Because we're going to miss that slender, Caucasian, healthy eating pregnant lady that does actually have gestational diabetes. And maybe she actually needs some medication and some help with that to achieve better outcomes. So the same circumstance, universal screening of all patients that present with preterm labor, and preterm labor symptoms are sneaky: pelvic pressure, pain, discomfort, back discomfort, diarrhea, nausea, vomiting, or the standard thing, uterine contractions, preterm contractions. I would argue, and I think you're going to better serve your pregnant population if you do a fibronectin test on every single one of them. You're going to rule out 80% of them. Importantly, you're going to find that 20% that has a positive that might come back and deliver within 3 days, and you're going to actually help that pregnant patient.
All right, I think we have time for one more question. And the last one is, what is the normal function of FFN protein?
The normal function is that it adheres the amnion and the chorion. It holds them strongly together. So the sac, the amnion, is well held to the placental cell layer, the chorion, which is connected to the myometrium of the uterus. It holds the pregnancy inside. It acts as a structural integrity of the actual pregnancy. And when that integrity starts to break and that fibronectin spills into the vagina as an actually detectable as a glycoprotein in the vagina, that is telling you that the integrity of that pregnancy is changing and she's at greater risk for preterm birth.
All right. All right, well, that's all the time that we have for today. I know Dr. Ruma has to run off to see some patients right after this.
Sorry about that.
So much. Thank you so much for joining us. And as a reminder for everybody who registered today, you will receive a copy of this recording following the webinar. Thank you for joining us, and I hope everybody has a great afternoon.
Be safe. Take care.